Okay, good morning. So, my remit today is to talk about pain in HIV disease. And what we're going to cover is the normal sort of layout of a talk. We'll go into a bit of the background of HIV and in relation to pain. It's an enormous topic. It covers almost every conceivable pain syndrome, so we've got to try and narrow it down a bit. And we'll talk principally about the HIV sensory neuropathy, and other particular areas of interest of opioids in HIV pain management. To talk about these particular topics, we'll need to have some familiarity with the HIV therapy, and then finally moving on to the sensory neuropathy, catch out differentials or red flags with regard to those particular patients and an approach to managing them, and like with many of the other pain talks, the paucity of good evidence at the moment. So, what's the actual scale of the problem? Well, this article you can see quoted at the bottom from 2010 lists an HIV prevalence of about 33 million. But you look at other articles and data sources, and many will give you figures of up to 40 million at the present time. So maybe 33 million is a bit conservative, but that equates to 2.7 million new infections per year, which is obviously huge. The initial disease model would be much more acute than this sort of chronic model we have at the moment, where life expectancy can be up to 24 years and even past that. And this model of disease translates into the pain syndromes that these patients will experience from basically the entire gamut of pain syndromes, acute, chronic and cancer. Probably though, pain should be considered in this group as to be generally chronic and with a significant impact on the patient's quality of life. Okay, so what's the prevalence of pain in HIV disease? Well, it's certainly highly prevalent. It's of course, like all these things, variably quoted in the literature, and probably a reasonable average quote is about 55%. However, I would think probably, bear in mind we're talking about any form of pain in a prolonged chronic disease model. I think you're looking pretty much higher than that. So who gets pain? Well, more commonly it's people who are more immunocompromised. There's some racial associations and people with sleep disturbance. But again, these are variably quoted throughout the literature. There is no doubt that pain is in itself undertreated in this population, and it's especially common in females, the less educated, and IVDUs, and particularly those where HIV has been transmitted through intravenous drug abuse. This leads us on to a little aside, and that is the subject of pseudoaddiction, and it's useful to think about in this population. So pseudoaddiction, as far as I know, was first described in 1989, or I guess first clearly described in that time. It's an iatrogenic syndrome. It's got three distinct clinical phases, and it's characterized by abnormal behavior patterns. The three phases are described as you can see, but the model, or the initiator of the whole sequence is of course inadequate analgesia, and there is no doubt that this is an at-risk population in intravenous drug abusers, and pseudoaddiction is something that you should have at the back of your mind when dealing with these patients, and certainly starting down the line of a escalating analgesic demand. The final result is of course this crisis of mistrust between patient and healthcare provider. Okay, so what sort of pain experience did this patient population have? As we said earlier, it's a chronic disease model, and so basically anything. So how are we actually going to categorize it for the sake of an exam? we've divided it into these 5 categories that you may or may not find useful. You can of course talk about acute, chronic, or cancer, or any other classification that you like, but this we've found to be quite useful. So we decided on pain as a directly related to HIV, such as a sensory neuropathy, and we'll talk about that more later, or HIV-associated neuromuscular weakness, or pain from organomegaly, liver capsule pain, for instance. Then there's pain directly resulting from immunosuppression, for example lymphoma, pain as a sequelae of HIV, so the opportunistic affections such as pleuritic chest pain, for instance from PCP pneumonia. Then there's pain in relation to HIV treatment, for example the HIV sensory neuropathy with a toxic cause, and we'll talk about that obviously more later. And then of course the pre-existing conditions, and again thinking back to the causative factor, so an intravenous drug abuser for instance may have vascular pain from injections, and with the presence of diabetes in any population. So as I said before, the entire gamut of pain symptoms is possible. This is obviously the HIV virus on attachment to a CD4 cell. So to understand a bit more about HIV and pain itself, we actually need to have some understanding of the drug therapy involved. And if we look back at the history of HIV and its treatment, it's really quite a remarkable 25 years plus in the treatment of this disease. So the history seems to relate back to 1959 with the reported mystery death of a male in Africa, and it wasn't until many years later that blood sample analysis showed this man had died of HIV. Where it really entered the public domain was in the early 1980s. An outbreak of Kaposi sarcoma was reported in the States. Some two years later, both French and American scientists appear to isolate the retrovirus at a similar time. I'm not sure who's actually claiming that. And only 5 years later, the development of Pseudoaddiction and its first approval by the FDA. Combination therapy is the sort of preceder to the heart therapy that we currently talk about, and this was essentially non-nucleoside reverse transcriptase inhibitors and protease inhibitors, and this was brought about through resistance or the impending problem of resistance to monotherapy. So where does it stand today? Well, in 2008 there are 25 anti-HIV compounds licensed. And most people will undergo a heart regime, and the starting of a heart regime is up to the experience of a experienced HIV physician. If you look at the different countries and some of their health agencies, they will all have different policies on when antiretroviral therapy should be started. So it's variable locally, it's variable nationally, it depends on the patient and their consent to obviously start this treatment. Their general health, and of course viral load and CD4 count. The most common forms of heart therapy are 2 nucleoside reverse transcriptase inhibitors plus a protease inhibitor, or a non-nucleoside reverse transcriptase inhibitor, or an integrase inhibitor. We'll just talk about the different classes very quickly. So the different classes of medications used in heart therapy, there are the entry inhibitors. These include things like enfuvirtide, and these interfere with the fusion of HIV in the healthy CD4 cell. The CCR5 antagonists, this includes maraviroc, and this will block the process of viral to cell attachment. Then you've got the nucleoside or nucleotide reverse transcriptase inhibitors such as stavudine and didanosine and zalcitabine, and a lot of these are thoroughly investigated in terms of their effect on HIV sensory neuropathy. Then there are the protease inhibitors, and these will aim to reduce viral assembly. An example of that is indinavir. The integrase inhibitors, which prevent integration of viral DNA, and that is an example of that is raltegravir. And then the maturation inhibitors, which reduce viral maturation, such as alpha interferon. Okay, so the main focus of our talk is going to be HIV sensory neuropathy. Unfortunately, like many of these things in pain medicine, it's not an entirely straightforward syndrome with clear management protocols. Before tackling any of these patients, you should actually be excluding any of the pre-existing syndromes, such as diabetic neuropathy, before diagnosing someone with having HIV sensory neuropathy. A few points about it. It classically presents as a glove and stocking distribution with predominantly stocking, and is a length-dependent axonal degeneration. The pure HIV sensory neuropathy is usually a combination of varying amounts, but two clinically indistinguishable conditions, and these are HIV distal sensory neuropathy and HIV toxic neuropathy. Most patients will tend to have a mixed etiology picture from this. So how common a problem is this? Well, the disparity in the literature is massive, anywhere between 8 and higher than 60%, and that probably reflects the heterogeneity of the studies looking into prevalence of HIV-SN. Some of them will have looked at symptomatic versus non-symptomatic patients. Some of them will have looked at whether this patient has been exposed to antiretrovirals, and some obviously haven't. So it's difficult to know where the figure actually lies. However, some of the bigger studies and more recent appear to be trying to address this, and a study of more than 1,500 individuals in the States, that's fairly recent, demonstrated a 57% incidence of sensory neuropathy, of which 38% had pain. One of the concluding factors is that this is one of the few neurological complications of HIV that appears to be increasing in prevalence. So as I was saying earlier, there are two distinct forms, although they appear to be clinically indistinguishable, and that is the distal sensory neuropathy, and this is associated with the severity of immunodeficiency, and then the toxic neuropathy. This is associated with many drugs used in HIV therapy, particularly the nucleoside reverse transcriptase inhibitors and some protease inhibitors, and other drugs that can be used in the whole treatment of these patients, such as vincristine or thalidomide. And the risks for getting this sensory neuropathy are increased in people who are taller, in the elderly. Again, some racial associations are possibly present with an increase in Afro-Caribbeans, and there's some genetic risk factors too. This picture has probably two most relevant parts when you're looking at the pathology or pathogenesis, and that is the GP120, and this is the sort of external, almost flowers-like appearance, and this is a docking glycoprotein on the viral cell. And other things to remember are viral protein R, which is also implicated in the pathology. So how does the sensory neuropathy of HIV actually develop? The GP120 we mentioned a minute ago is one of the viral coat proteins, and GP120 acts by assisting in the binding and transmission of HIV into host cells through particular interactions with the chemokine receptors, particularly CCR5 and CXCR4. GP120 appears to be directly neurotoxic. When it's applied to a nerve, it will lead to axonal disruption and an inflammatory state. So a process of nerve damage and a pathway to lead to hypernociception, which is the basis of any painful sensory neuropathy. The whole process is quite complex, and it involves direct and indirect injury. There are several key players, GP120 as we've just implicated. On the intracellular level, there's mitochondrial caspases. Glia appear to be implicated as well, and the inflammatory cytokines I'm sure everyone in their revision is becoming so familiar with, in particular the interleukins and TNF-alpha. Overall, the interplay between all these different elements is actually quite complex. The toxic neuropathy side of things is slightly different in that the mitochondria is the main source of the problem. The distal sensory neuropathy appears to have more direct viral coat protein effect and the production of this inflammatory state. So, as we've been saying, the GP120 docking protein appears to be one of the major implicating factors, and you can see it here. And its actions are both direct and indirect. And directly, at the bottom or the middle right of your screen, you can see the the GP120 binding to the axon, and this leads to activation of mitochondrial caspases. Now, these are proteases which play an essential role in apoptosis. So any activation of them by the GP120 will cause axonal destruction through apoptosis between the Schwann cells of the nerves. The GP120 will also cause a indirect nerve injury, and this occurs at the level of the cell body. An activation of the chemokine receptors on the macrophage that you can see, or the slightly fried egg looking thing to the right of the cell body. This again appears to have an action through IL-1 and TNF-alpha in particular, and then that, once internalized, will cause further caspase activation and further apoptosis. So that's how the nerve injury appears to occur. They then need to lead to a hypernociceptive state, and this is essentially predominantly an inflammatory state, and therefore is indirect. So peripherally activated chemokine receptors will cause membrane depolarization and sensitization, and that occurs through the TRPV1 channels I'm sure we've heard about elsewhere, bradykinin receptors, and substance P release. At the axon level, GP120 will cause macrophage infiltration, and this again releases further TNF-alpha. And at dorsal ganglion level, GP120 promotes the release of pro-nociceptive chemokine ligands and TNF-alpha again. As I was saying earlier, the toxic neuropathy part of the sensory neuropathy appears to be predominantly mitochondrial, and there have been many of the nucleoside reverse transcriptase inhibitors implicated. Probably the most commonly studied is zalcitabine. Stavudine itself has actually been withdrawn from the market now in many countries. So what's our clinical approach to a patient with HIV sensory neuropathy? Well, like all of our patients, it's a mixture of history, examination and investigation, producing a diagnosis and exclusion of other differentials. I think what we will particularly want to be aware of is recognition of red flags, and they're covered quite clearly, in particular the differentials, in the clinical notes attached to this talk. In particular from the history, what we want to know is the onset of symptoms and see if we can relate the onset of these symptoms to any new drug or change in drug dosing. We want to look at, in particular, the rate of progression of these symptoms and combine this with an idea of the immunocompromised state of the patient. When we're doing this when we're looking at this particular population, we are thinking glove and stocking peripheral neuropathy. The clinical picture of HIV sensory neuropathy is a glove and stocking neuropathy. So it tends to start in a stocking distribution. Spread is obviously proximal, and hands appear to be affected later on in the progression. In some cases, where the implication is that it's toxic neuropathy only, the neuropathy may start in the hands. There is a sensory loss to all modalities of sensation, so a full sensory examination needs to be done. In most cases, with the stocking loss of sensation, there is an absence of the ankle reflexes. When patients describe the pain associated, they describe all the common neuropathic symptoms: numbness, dysesthesia, paresthesia, etc. Motor signs do occur, but they tend to only occur in the really advanced stages of the disease, and they are rare and should be considered a red flag in this population. So, with regard to red flags and how you're actually going to go about investigating, I'm sure in this course the full method of neurological examination has been covered in the peripheral nervous system. So, most investigation is actually pretty unusual and often unnecessary. Most cases, to be honest, are usually fairly clear. But there are two major red flags that need to be considered, and that's early onset of motor signs and rapidly ascending sensory loss. And when you look through the clinical notes, you'll see all these different potential sensory neuropathies. Some of them are catastrophic and associated with infection, and they are Guillain-Barré syndrome and an HIV form of Guillain-Barré that is not that uncommon. Then you've got to think outside the HIV box itself with regard to Cordra-Quina syndrome, and this would obviously mandate an urgent MRI, and constitutional symptoms that include fever and weight loss would implicate the need for a lumbar puncture. Full examination will exclude other forms of mononeuropathy such as herpes zoster. As I said at the beginning, when starting out in the management of these sort of patients, you've actually got to consider that this sensory neuropathy is from a pre-existing cause, and all this other sensory neuropathies I'm sure will be covered elsewhere in this course, but things that would be running through our minds would obviously be diabetes, alcohol and thyroid dysfunction, and of course vitamin B12. In this group we would also be thinking of hepatitis B and C serology, and renal function is mandatory in this population too. You would then go about investigation if there is a uncertain diagnosis, as you would for any other sensory neuropathy, in the forms of EMGs and nerve conduction studies. So the approach to managing this condition is obviously, number one, to think of the other neuropathies and how we can go about treating them. Then we've got to consider, can the underlying cause of the neuropathy be removed? This is not a decision that a pain specialist should be making, but a discussion with one of your HIV specialist colleagues would be helpful. And most people would then go about instituting an anti-neuropathic agent. But similar to the other talks, this is where things start to fall down. This meta-analysis from 2010 has been pretty damning about the current pharmacological therapy in HIV neuropathy. Now, the only drugs that this meta-analysis showed were superior to placebo were smoked cannabis, which is illegal in most countries, recombinant nerve growth factor, not commercially available, and 8% capsaicin topically, which many people don't take to that well. So every other anti-neuropathic medication was not considered to be superior over placebo, which is pretty damning. I can't recommend highly enough UpToDate.com, and there's some really good reviews of the clinical manifestations of sensory neuropathy, and in particular the differential diagnoses, and these will be of particular use to the neurological clients of this course. For the average pain specialist, it's probably a little detailed, but they list a management plan that, and they've graded the level of evidence as you can see in this slide. Hopefully duloxetine will be a source of or potentially a useful therapy in the future, as many consider this to be similar to the diabetic neuropathies. Who knows? So we mentioned at the beginning that we're going to briefly mention the role of opioids in pain and HIV. No discussion with regard to opioids can get past a certain few facts, and that is in particular that many of, or a significant portion of this population may actually have contracted HIV through opioid abuse itself. Then there's recent evidence which shows that HIV itself may actually be pro-infective, and this appears to occur through promoting HIV infectivity by reducing the secretion of certain chemokines. And these chemokines normally inhibit the chemokines that are required for HIV expression. So it may well be that opioids in HIV state may be actually pro-infective. Opioids may be pro-nociceptive. There's obviously talk of opioid-induced hyperalgesia, tolerance, etc. In particular, in this case, their pro-nociceptive effects may be through the upregulation of certain chemokine receptors, particularly CCR3 and R5. The cytotoxic effects of GP120 that we covered earlier can be affected through intracellular calcium modulation and possibly direct or indirect glial effects. Opioids are in long-term use in this population and at a higher prevalence than normal. It's obviously no surprise that HIV individuals consume more opiates than non-HIV. But this occurs particularly in women and if they have concurrent medical conditions. Again, it would be no surprise that any person with a history of substance use or misuse, and anyone who contracted HIV through intravenous drug abuse is much more likely to be a long-term user of opioids. We discussed the problem with regard to pseudoaddiction earlier, and that has to be kept in the back of our mind if we're dealing with this particular population. And the other thing to consider is that almost all antiretrovirals interact with opioids, in particular methadone and buprenorphine. So the opioid using population of people with pain and HIV can be very difficult to manage and treat. So that pretty much takes us towards the end. As I say, this lecture goes in conjunction with the clinical notes attached on the course. Just to summarise a few things, we should know that pain is common. It covers the entire gamut of pain symptoms and signs in this chronic disease model. It's frequently poorly treated and is frequently poorly treated in often a difficult group of patients. The main thing, or the main syndrome we will probably cover as pain physicians, is HIV sensory neuropathy, made up of the two, the distal sensory and the toxic neuropathy. When we're investigating any patients with sensory neuropathy, most investigations are unnecessary, but be aware of the red flags, and that's in particular constitutional symptoms and motor weakness and a rapid progression of the symptoms. And then unfortunately, like similar talks, there are very few anti-neuropathic agents that really are coming up trumps with regard to treatment. And a special consideration should be, you should have a special consideration for the opioid using patient in this particular population. Thank you very much.